Within the TNF world, there are a variety of choices. And so we go back to some of the early ones with adalimumab as a monoclonal antibody protein. We have etanercept as a receptor fusion. We also have infliximab, which is another monoclonal. And then after that, we had golimumab that comes along both as a sub-Q form and as an intravenous form. And then finally, certolizumab, which is a pegylated sub-Q, whether it's physician administered or patient administered. So across all of these, we're looking at something that is going to block the TNF pathway. How do they differ? So when we look across the entire class, these are all very effective drugs. Some patients may prefer one over the other. For instance, there's data with certolizumab looking at transfer across the placenta, transfer in breast milk. And so for a young woman, that may be an option because if she's trying to get pregnant or is in fact pregnant, she may prefer something that may not cross the placenta and get into her baby. In terms of efficacy, there's lots of data with adalimumab and etanercept and infliximab. So again, lots of choices across that spectrum. Some of these agents can be used as monotherapy, meaning no background therapy required, and the most common background therapy is methotrexate. So if I have someone who does not or cannot use methotrexate because they've had either toxicity or adverse events, and you say, well, what would those be? Well, if there's a liver damage or her cell counts are low, or, oh my gosh, she's losing her hair. A 31-year-old going bald with methotrexate, not so inviting. But outside of that, some people get nauseous and very fatigued. So not everyone can tolerate methotrexate. And so we look for those agents that we have substantial evidence that are effective and sustainable in the absence of methotrexate. So the TNF inhibitors are a class. And then we have the IL-12/23 inhibitors, ustekinumab being sort of the most prominent one that we've had for some time. And that really has been used for psoriasis extensively, and more so now with psoriatic arthritis, again with efficacy being shown there, and various routes of administration with ustekinumab. And then finally, in the IL-17A inhibitor class, we have ixekizumab and secukinumab, both inhibitors of IL-17A, and both with data that shows effectiveness both in the skin and the joints, with or without methotrexate. So lots of efficacy data, lots of discussions about what's going to work best. And there's data showing even superiority in some cases of one drug class over another in certain studies. But again, for that individual patient, that's a discussion based on her choice.